I am going to be I'm going to be presenting on trauma and first episode psychosis. And one of the things that I want to share as we kind of talk about why trauma, why is it something that we're going to talk about? And got a couple of points here on the slide to think about, but and we'll talk some more about each of these points as well. But I just want to kind of highlight the fact that the majority of individuals that are coming into a CSC for FEP program are going to be experiencing some form of trauma or have experienced some form of trauma. And oftentimes it's overlooked or it's missed. And one of the things also that we'll talk about here towards the end of the didactic is the impact that it has on providers and the difficulty that sometimes providers have with looking at trauma, especially with individuals experiencing their first episode of psychosis and the fear of what might happen by addressing that trauma. And so we'll talk a little bit about that. So when we talk about trauma, a couple of things to remember is that it can result from an event, a series of events, a set of circumstances, and that it's experienced by the individual is physically or emotionally harmful or life-threatening, and has lasting effects on the individual's functioning and mental, physical, social, emotional, spiritual, all those areas of their life, their well-being. And one of the things that I'm hoping that we can touch on and to think about when we talk about trauma, that's a very powerful word, a very powerful term. And so a lot of individuals that we're working with may be reluctant to look at trauma or use the word trauma or talk about trauma. And so we want to think about the way that we approach talking with individuals about what it is that they've experienced, what terminology we use, and the way that we open the door. One of the things as providers that I think we lose sight of is that it is a privilege to hear someone's story. That individual is telling us something about them that maybe it could be very personal, could be very difficult, could be very uncomfortable. And so we need to approach that as this is a privilege that the individual is sharing their experience and their story with me. And trauma is very much in any form, trauma, stressful experiences, stressful events, very much in that realm as well. One of the things that I wanted to touch on as well is racial trauma. Mental Health America noted that when we talk about racial trauma, sometimes referred to as race-based traumatic stress. It's any individual that has experienced an emotionally painful, sudden, uncontrollable racist encounter. Here in the United States, we're looking at individuals that are most vulnerable and most impacted are Black, Indigenous, people of color individuals. And it can result from direct experiences of racism. It can be vicarious. And it can also be transmitted intergenerationally, which is something that I'm going to touch on a little bit. I attended a conference back in September, and I learned a great deal about racial trauma and the impact from generation to generation that it has on individuals. And so when they talked about racial trauma, just to kind of highlight a couple of examples, I'm sure most of you are familiar and know that, right quickly after the outbreak of COVID, there were a number of events, incidences of anti-Asian racism, up to 1,500 in 1 month after that had occurred, and could have been physical, verbal attacks, anti-Asian discrimination in private businesses. So it happened relatively quickly after that. And then the other area that was just mind-boggling to me is that in 1 year, Twitter saw over 4 million anti-Semitic tweets in English alone. And they included, stereotypes, promotion of anti-Semitic personalities or media, symbols, slurs, conspiracy theories, including Holocaust denial. And so it's one of those areas when we talk about racial trauma, we want to pay attention to when we're working with individuals and looking at the impact that it has. I mentioned that back in September, I attended a conference and it was entitled Understanding the Impact of Racial Trauma on Youth and Emerging Adults. And one of the presentations within that conference was entitled Cultural Humility, Laying the Foundation for Abolitionism. And it was by Dr. Adrienne Kennedy and LaShonda Suggs. And during this presentation, they talked about racial trauma. And some of the content that I'm going to be sharing with you was information that they had presented based on a book that was entitled My Grandmother's Hands by Resmaa Menakem. I have it right here. In full disclosure, I haven't read the whole thing, but what I have read has been very, very enlightening. And it certainly has changed my approach in looking at racial trauma. But when we look at racial trauma, looking at the impact that it has on individuals, and the reason that I'm going to highlight this is because we want to recognize that some behaviors that we might see from individuals, we may misinterpret or we may not understand based on the way that they're reacting, based on the impact of racial trauma that they have experienced. And so looking at some of these, when we talk about images and thoughts, disjointed thoughts, intrusive images, difficulty with dreams, flashbacks, certain behaviors, avoidance, seeking out behaviors, adverse reactions to things, body movement, and then meaning making, comfort and safety is conflated. And so sometimes when an individual that has experienced racial trauma, what they might be experiencing is a lack of comfort. They might be uncomfortable, but they're interpreting that as danger based on what they have experienced. And so when we're looking also at behavior, avoidance and seeking out behavior, food, for example, right? And so sometimes individuals may eat too much or they may eat too little as a response, and how racial trauma may impact them. So one of the things that they touched on was the idea of the fear cascade. And I thought this was a really interesting, again, very enlightening way to look at the impact of racial trauma and how individuals, I don't want to use the word cope, but how they react to racial trauma. And so we look at things like fight, so this is the old flight or fight kind of response. So the physical fight, physical altercations, could be sarcasm, could be things like activism, could be a way to kind of work through that fear. There's a flight response. And ultimately, when we talk about racial trauma, when we talk about the flight response, it's about gaining safety through distance. So oftentimes the individual is trying to escape that trauma, or they have a response based on a previous trauma. It's not that they're trying to run away. They're trying to get to safety. And so it's their response to that. And it kind of goes along with the freeze response, right? And so in the absence of safety, we know, our minds will tell us, okay, what needs to be done? This is what I need to do. But sometimes the body doesn't cooperate with that, right? And so we might think, okay, I gotta go. I gotta get out of here really quickly. But we just kind of freeze. And so I think that's important to recognize, because it's a response. It absolutely happens. We want to think that when we're confronted with safety that we'll be able to do that, and we oftentimes can't. And then there's a flock as a response, right? So this is through gaining safety with others. So if I start to kind of be around individuals, that's going to create my safety net, or that will protect me. And then there's fawning, which is really a form of accommodating individuals. And the hope is that, okay, if I do this, that the danger will go away. If I can just kind of accommodate whoever may be perpetrating or whoever I have experienced based on that trauma in the past. If I can just, try to appease them, then that won't happen again. Dr. Uwemedimo had a fantastic quote that I wanted to share with all of us, because we are all working in first episode psychosis. And, as part of a CSC for FEP program, we talk a lot about resilience, and we talk about praising individuals for their resiliency when it comes to areas of their life that they struggle. And this quote, I think, is really important for us to take to heart and to think about. And I'm just going to read it here because I think it's really important to see and to hear. I don't need you to praise me for my resilience. I need you to stop creating spaces of trauma where being resilient is all that I'm allowed to be. And so I think that's something that we need to think about when we talk about resilience with individuals. Are they in situations, or do we continue to put them in situations where that's all that they have? And that's something we need to examine and we need to look at. So when we look at the psychosis and trauma connection, okay, so trauma exposure may contribute to the development of psychosis. There's not enough research right now that can tell us how or why that happens. We just know that there could be a role, that it could be a factor when we look at psychosis and trauma. Individuals with psychosis are high risk for traumatization, and that's through victimization, and also because sometimes symptoms and some forms of treatment that individuals have had as a result of their symptoms, their psychosis, may be traumatizing. And so it's this interconnection that is happening as a result of both things being present for the individual, one leading to the other, if you will. And then without effective treatment, trauma and psychosis can interact in this cycle of vulnerability. So it can alter developmental trajectories, and it can lead to less successful outcomes potentially. And so both need to be addressed in order for full, complete recovery to be possible. Some information as far as prevalence, and I laugh at this because when you look at the literature, you're looking at half to all individuals with psychosis have experienced a traumatic event, a traumatic experience. So this isn't something that when you're working with an individual in your program, this isn't something that happens infrequently. This happens quite a lot. And PTSD among individuals with psychosis is 10 times higher than the general population. So we talk about a trauma-informed approach, and trauma-informed approaches are consistent with coordinated specialty care programs. Shared decision-making, ensuring safety for individuals and team members, communicating with transparency, providing education, supportive supervision for team members. So trauma-informed approaches fit in well with a CSC for FEP program. The components are there. It's about utilizing that approach. And so trauma-informed approaches use the 4 R's, for those of you that might be familiar with that. So it's realizing, recognizing, responding, and re-traumatization. So the idea is to avoid re-traumatization, obviously, but utilizing the 4R approach. And one of the articles, one of the pieces of literature that I pulled from was Cragen and colleagues, and I'll talk a little bit more about that as well in a little bit, but it identifies the difficulty on behalf of providers when addressing trauma and early psychosis. And really, as I mentioned earlier, it's a fear of what's going to happen next, kind of the fear of the unknown. Is it going to increase psychosis symptoms? Is it going to are they going to be more resistant or reluctant, quote unquote, to return to treatment because they're not wanting to talk about the trauma that they've experienced? Maybe because they're afraid of what that might lead to or what the response might be. So I have another quote here that I think is really, really powerful and to think about, because there's a difference between saying we take a trauma-informed approach and actually taking a trauma-informed approach on behalf of teams, on behalf of organizations. But I think that this is a really important way to look at self-care for providers when we're working with individuals that have experienced trauma, because it is a very powerful experience. And so I'm going to read this quote here. This is by Heidi Miller, who is a part of the Family Health Centers of St. Louis. And she said, you have to create a healthy organizational environment in addition to emphasizing self-care. It doesn't matter how many deep breaths you take if the air is polluted. And so very powerful way for providers to think about when working with individuals, what can they do and what can be helpful. So I know I'm running close to being out of time here, so I wanted to touch on a couple of things that can be utilized as part of assessing trauma and treating trauma for individuals in FEP treatment. And so the PCL5, it's available through the National Center of PTSD, which is within the U.S. Department of Veteran Affairs, and the website's listed here. And when you get materials from this presentation, the PCL5 will be there. It's a very simple measure to utilize in terms of assessing trauma. And they have lots of instructions, kind of a walkthrough for providers to read through that kind of explain to them how to use the measure, kind of what are some scores to consider for further evaluation or what might be helpful in terms of next steps. And so it is a very useful tool, very simple, not very time consuming in terms of assessing for trauma. And then, as I mentioned earlier, Craig and colleagues, when they were talking about trauma and FEP individuals, they completed provider surveys where the providers identified barriers. And so I'm including this here because I want everybody to think about what barriers might be in place for them when it comes to using a trauma-informed approach in working with individuals. So some of the barriers that they identified, and these were specific to FEP programs, for CSC for FEP programs. And so they identified things like differentiating trauma exposure from psychotic experiences. They talked about symptom interference or exacerbation, inadequate training and supervision, discomfort treating both trauma and psychosis. And this was on behalf of the providers. And what they utilized in another piece of literature that was out there was Folk and colleagues. They utilized the trauma integrated cognitive behavioral therapy for psychosis. Now, this was out in California at UC Davis. And trauma integrated CBTP, I'm just going to do TICBTP. It combines several different evidence-based practices. So CBTP, trauma-focused CBT, prolonged exposure therapy, cognitive processing. It was kind of incorporating all of those. And they used a stage-based approach based on the individual's progression in the CSC for FEP program. So it's kind of based on how they're progressing, how they're doing symptomatically, it kind of would highlight the next step in this TI-CBTP. And while the sample size wasn't large in terms of individuals that engaged in this, they didn't find any detrimental effect or exacerbation of psychosis symptoms. And as I mentioned, that's a common concern. And that wasn't anything that they found in utilizing some of these various techniques and working with CSC for FEP individuals. I had going to share some information that was shared with me by Dr. Valerie Kreider when it comes to addressing trauma in FEP programs. And so just kind of highlighting these again, in the interest of time, I'm not going to go through every one of them, but it is important to recognize the idea, I think, looking at this, is the idea of patience and recognizing that there might be times with individuals you're working with where they may be very open to talking about what they've experienced. And then there might be times where they're not. And so as they are talking, paying attention to that, using that, listening to those, what they're sharing. And then if they come in and they say, you know what, I don't want to talk about that, that's okay, right? I mean, and it's okay to recognize that this just isn't the time where they're hoping or wanting to address those as well. One thing I do want to highlight is when we look at trauma, assessing if it is ongoing, because we want to assess for safety. And so for individuals that we're working with, if we feel or we have concerns that that trauma is current, we want to make sure that we assess for safety and help them to develop safety plans, next steps, things that might be helpful for them as they progress. And the book that I had talked about, My Grandmother's Hands, Resmaa Menakem had a quote here that I think is very powerful, especially when we talk about trauma. And it says, healing involves discomfort, but so does refusing to heal. And over time, refusing to heal is always more painful. And so I thought that was a good point to close on. when we're working on and looking at working with individuals that have experienced trauma. So I am going to go ahead and stop my share.